We have Dr. Rohit Shetty with us over here, who is the chairman of Narayan Nethralaya, Bangalore. And we have Dr. Girish Rao, who is a well-known retina specialist. As chairperson of this session, we have our former ARC chairman, Dr. Chitra Ramamurthy. And so we have 3 judges over here. So we'll start the session because we are already behind schedule. We were adding up.
No, Dr. Kim was sitting in the other hall and he was very particular that he has to come here.
तो 1 मिनट बुला लेते हैं, 1 मिनट रुक जाते।
वो सामने वाले वो LDP हॉल में। Universal slit lamp adapter. On to you.
Good afternoon. Can I have the presentation on the screen, please? Presentation on the screen, please. Yes.
We would like to congratulate all the winners of the different session. It's quite a feat to reach to the final, so a big congratulations to all of you.
Good afternoon. My topic is universal slit lamp adapter for a mobile phone. I'll start the presentation since it's a video presentation. Yeah. It's FDA approved and patented. Can I have the volume, please? Can we please have the volume? Oh, just stop them. Okay. Can you reset the timer?
Documentation have become mandatory.
Can you reset the
Not only
Can you reset the
slit
timer,
lamp
please?
imaging and documentation have become mandatory, not only for patient education, but also to safeguard a surgeon from unnecessary litigations. The pre-existing slit lamp imaging adapters that are available in the market are either very cumbersome to use or require holding the slit lamp adapter and the phone together using both our hands. On the other hand, slit lamp adapters with beam splitters are very expensive. Introducing the US FDA approved and patented universal smartphone based slit lamp imaging adapter. The device has been designed keeping in mind the cost effectiveness and to help digitalize your slit lamp to capture images to educate patients about their conditions. You will find all the components in the box. Slide the base of the adapter onto the rotating arm. Attach the smartphone holder on the base and lock it in position using the knob. Attach the smartphone on the phone holder. You can use any smartphone of your choice. The device is compatible with majority of slit lamps. The device has a unique design that enables it to be mounted on the handle of the slit lamp and can be rotated in and out with the patented swivel technology. One can align the smartphone camera to the right eyepiece of the slit lamp. The distance between the smartphone and the eyepiece is typically 3 to 5 millimeters. Fix the assembly on the slit lamp by tightening the screws. The device is now permanently installed on the slit lamp. The operator is now doing a routine slit lamp examination without any interference. Then he rotates the device into the right eyepiece of the slit lamp. He can then open the camera and capture images or video of the eye. Once the image is captured, you can print them and also show it to the patient. Our device has various advantages over the other devices, such as it is cost effective, it has a universal slit lamp compatibility. Not only it has a universal mobile compatibility, but it can also be used for telemedicine as it is extremely easy to use. Thus can also be operated by an optometrist. Using any screen mirror application, the video can also be portrayed on a television, thus helping the patient and the relative understand the condition better. Here are some of the images that we have captured in the last few months.
Thank you.
Thank you, Dr. Neeraj. Judges, please.
So, what's your commercial model? How do you want to take it commercially?
So this is
First question is, you said it's a FDA approved.
yes.
What is FDA
Okay.
approved means?
So FDA approval is only given to a company, and usually when you form a company, that's you have to apply for FDA approval.
But that's something which has to be specified because this device is not FDA approved.
Yes.
So
We have formed a company now.
Exactly.
And
so
the company.
that's why I know sometimes it gets confusing because device is different, company is different.
Yes.
Device getting FDA approval is very, very long
Difficult,
and cumbersome.
yes.
However simple it is. So
Yes.
that's something which you have to change in the video.
Sure, sir.
And how do you want to? What's the commercial line?
Sir, this is now available I have handed over to one of the companies, and it is available in this AIOS only. We are selling it. So if you see, I have the commercial device over here with me. It is made out of ABS plastic, which is the same material used for all your slit lamp tables, OCT outer coatings, and
Thank you.
thank you, sir.
Thank you, Dr. Neeraj. I'd like to request Professor Jeevan Titial sir to please give a certificate of appreciation to Dr. Neeraj.
We call our next speaker, Dr. Mukesh Dholakia, who is going to talk on versatile universal IOL injector adapter to motorized IOL injection.
ये नहीं मेरा नहीं हाँ yes that's you will please move on the slide. Versatile and universal IOL injector adapter for motorized IOL injection by Dr. Mukesh Dholakia. Next please. So we have applied patent for this innovation, please. A motorized IOL injector system injects the lens into the eye after completing the phacoemulsification of cataractous lens. It has smooth and controlled IOL delivery so that most IOL delivery related complications can be avoided. Injector is operated by foot switch, leaving both the hands free for better maneuverability and precise positioning of cartridge for smooth IOL delivery into the eye. Next, please. There is one IOL injector available in the market by Alcon, but it is meant to be used for specific brand of the lens only. It comes with phaco machine console, so it's very bulky. Hence, it's too expensive to be afforded by any small setup novice or even a veteran eye surgeon. Next, ours is a IOL injector adapter, and it can be used for any brand of IOL and injector combinations, and it is not motorized IOL injector, so it doesn't infringe any company's patent rights. Next, please. So we have used 12-watt small DC powered motor. A metal adapter is made, an actuator. In engineering words, it is called actuator is made. Next, please. Before that, please. Yes. So ours IOL injector adapter, it can adapt any IOL injector. So any company's IOL injector can be converted to motorized IOL injector. Second, no heavy investment. It is a very sleek, lightweight design and standalone unit. And it's versatile so that any company's IOL and injector combinations can be also used. Next one. So these are two versions at this moment I have made. There is a small motor. Can I use this? Please. So this is a small 12-watt DC motor having 3 millimeter shaft, and this adapter is made by me in version 1. This is another version, and this is a disposable injector, and this actuator is made by me, and this is practically holder. Next, please. So this is a foot switch having forward and reverse movement possibilities. We have devised a small chip for this, and it can be controlled by rheostat mechanism. So motor RPM can be controlled by ourselves on table as well as preset. Next, please. Please play the video. So this is the version which is in use in actual. So in my right hand, I'm holding the IOL injector holder, and there is one injector which is disposable, and in my left eye, globe stabilizer is there. And इसका आवाज करते तो बहुत अच्छा. On next one. Loud voice, please. वहीं से चालू कर दो प्लीज. So one can hear the sound of motor. So the injection is in progress. I can manipulate the
time is up. You can stop it and go for questions.
Thank you, Dr.
Next.
Mukesh.
Yeah.
Judges.
If any of judge want to see my adapter, actually I have come with it. If anybody is interested, I'm here.
So what is the actual advantage of this over what has been conventional?
Yes, sir. So Alcon has come with the thought that IOL motorized injector will obviate all other possible complications of manual injection. You need a tactile feedback. So if your tactile feedback is not proper, then you can overshoot, you can forcefully inject the lens, you can, so many things. And it is not too manual. It is, your one hand is already occupied with the injector and the other hand is stabilizing. Here both the hands are free to maneuver the cartridge and to maneuver the globe, both the things. And you can adjust the speed of the motor also. I'm sorry, but my second slide, because of some hassle, I could not see.
The speed of the injection is foot control?
It is foot control. It has dual foot forward and reverse movement. You can stop, you can restart, you can adjust the speed of the motor. Means if you want to inject the lens in 30 seconds, you can. If you want to inject the lens in 20 seconds, you can. If you want to inject the lens in 15 seconds, you can. And we are now with next version, we are there to stop the lens. Once the lens reaches at the nozzle, tip of the nozzle, it will stop there. Same as like in Alcon.
Dr. Mukesh, the same question I'm repeating. What is the need of this? Today we are shifting to preloaded lenses.
Sir, preloaded can be fitted to this my injector.
Then what's the point of having preloaded?
Sir,
the advantage of preloaded is go off.
Sir, this is injector adapter. So we are not, see, cartridge is not, we are changing. Everything is there.
Each lens is coming with the
Preloaded can be
injectors.
fitted, preloaded can become motorized, sir. Motorized preloaded has not come yet into the market, sir. Not a single motorized preloaded has come.
What's the cost of this device?
Sir, we are working with the companies, but it should not be more than 25 to 30K, please. It is standalone. You need the motor is just 1,000 rupees costing, and other stuffs maybe 2,000-3,000.
And the metal, the make of that?
At this moment, I have made with aluminum, but it can be made with steel, with titanium. We can make it with the silicone and Teflon. Anything can be made.
Thank you, sir.
Thank you, sir.
Dr. Atul.
Talk on slit lamp sensor sustainable solution.
We have to get the names printed on the certificates. So for everybody, we'll write finalist and give it at the end later in the evening once it's typed. Can you reset the timer, please?
Checking.
Timer को फिर से on करो.
Good afternoon. When the world is moving to sustainability in ophthalmology, how can we contribute to the sustainable development of our future and forsake and save the future generations? So I hope you all have a nice experience watching this video. Enjoy the show, please.
Hi, the doctor that you see next to me is solving one of the commonest problems in the OPD.
Hi, my name is Lakshana.
But let me first tell you what the problem is. Wastage. Slit lamps in OPD are kept on even when they are not used. And according to data, cross-infection through the slit lamp is quite common. So when Lakshana noticed the same happening at the hospital she was working in,
I had to do something about it. How about an attachment to chin rest of the slit lamp at a very low cost, which can be used in all the OPDs and vision centers, and also it is easy to install and it should be easy to handle. Finally, a sustainable model to save electricity and also the lifespan of the bulb.
the doctor, with the help of instruments team, drew up a circuit, acquired all the parts, and dedicated her time
To fix the problem.
They came up with an infrared sensor that can be fixed on the chin rest. It lights up when the patient keeps the chin on the chin rest, and it turns off when they take the chin away. You can imagine the difference it can make.
If we can do this for one slit lamp, we can do this for the entire hospital.
So, she's in the process of avoiding wastage in her hospital. Many doctors have already started using this innovation.
I found this innovation to be very useful. Whenever we see infectious cases, we don't have to keep touching the switch on or switch off the light. And this greatly reduces the transmission of infection.
Sensor switch is really useful both in improving the compliance for the patient. I think that's one of the most important things. Only if the patient keeps the chin, he realizes the light gets switched on. So many a times patients have tendency to lift it off. So that is one thing. And then the comfort level, unnecessary waste of resources is one of the plus points of this slit lamp sensor switch. I think this is a very, very useful tool.
What is the technology you have used?
IR sensor is fixed beneath the chin rest. This sensor controls the slit lamp bulb's input. when an object of interest, in our case the chin of the patient, comes in close proximity to the sensor, it gets activated, switching on the slit lamp bulb, which in turn helps to prevent the wastage of electricity.
And why don't more people do this? That's why the team is thinking big. They want to spread this innovation all over the world. The team is now working on a DIY kit which can transform existing slit lamps with a simple clip-on addition. With an entire team, bioengineering, effective technology, and a noble goal, they are reducing wastage of resources. The future is bright indeed.
Thank you.
You have looked at any other commercial slit lamp which has this inbuilt?
The conventional slit lamps?
The current day slit lamps, any of those models have this?
Most of the slit lamps that I have researched upon in our institute.
Hack Straight is already having it. Hack Straight new model, or I don't know whichever models. Most of the Hack Straight, when they go in, it gets off, and that's the model I use. So of course, good innovation.
So we are planning on a clip-on for existing slit lamps. You can have a clip-on addition. If we clip it on, it can be connected to the circuit, and it can probably the feature which is available in Hack Street, like Sir suggested, can be made available to other slit lamps as well.
Just try to see how they have done it.
Yes, sir, definitely. Because, sir. I was in talk with Aura Lab. They had given me the information that it is.
If you look at how they have done it, you might get some ideas on it.
Definitely, sir.
Thank you, Dr. Atul.
Thank you, sir.
The next speaker will be Dr. Santosh Agarwal, who will be speaking on an innovative, simple and novel AC paracentesis device for safe intravitreal injection.
Yeah. Thank you, moderator sir.
Iske baad.
Respected judges and chairman's desk, and thank you for the opportunity. I am going to present my video on intravitreal injection, an innovative technique, along with the PPT also. So intravit injection is now widely used to administer anti-VEGF, triamcinolone, antibiotics, etc. So what are the risk factors which are involved in the technique? The vitreous incarceration in the wound, vitreous leak through the scleral tunnel, a bleb formation at the end of the injection, an immediate rise in the IOP and potential complication like optic nerve disc perfusion, transient CRA occlusion, an increased risk of endophthalmitis, and also the RD because the vitreous is adhered to your inner wound. So this is my simple and novel AC paracentesis device. Prior to injection, paracentesis is done with 26 or 30 gauge needle whose hub is mounted on a sterile Johnson bud so that you will have a guarded egress of the aqueous. It remains inside antechamber throughout the injection to drain out aqueous as the intraocular volume is increased because of the intravitreal injection. Chances of iris and lens touch can be avoided by piercing the needle at the limbus tangentially, and the bevel is partially inside the antechamber. It will not touch any iris or intraocular structures. It is just inside. 1/4 of the tip is inside the antechamber. So what are the advantages? There is no immediate hypotony or AC collapse as against direct bare needle entry that will cause hypotony, and you cannot inject intravitreal injection. So it is a guarded egress of the fluid. While giving intravitreal injection, aqueous drained out slowly in a guarded fashion. It is soaked into the tip of the bud. It avoids immediate rise in IOP and its potential complications. Mostly it is useful when triamcinolone or multiple injections are given in case of endophthalmitis. There is no vitreous or drug reflux at the site of injection. There is no vitreous leak and its potential complications. There are less chances of endophthalmitis, and there is practically no need to check fundus or vision post-injection. There is very less discomfort or no pain at all. So this is the study, this is the video. Now this is the pre-injection paracentesis needle which is in the antechamber. Just the tip is inside it, and I have given the intravitreal injection. There is no rise in IOP, and it is very safe. Now this is the 26 gauge needle, and the Johnson bud is just pierced or mounted on the hub of the needle. This is 30 gauge needle. Any needle you can use. Now this is the intravitreal injection. This is the pre-injection paracentesis. There is no hypotony as it is having. Now intravitreal injection is given, no rise in IOP, no vitreous weak or any egress of vitreous or fluid from the scleral tunnel. So again the same. Now this is the sound please. This is a reaction of the or feedback from the patient.
क्या आपके इंजेक्शन दिया है? आंखों में इंजेक्शन दिया है. हाँ. तो इंजेक्शन के मेरे को चीटी काटते इतना भी दर्द नहीं हुआ. बिल्कुल भी दर्द नहीं हुआ. मालूम भी नहीं पड़ा इंजेक्शन दिया कि नहीं दिया तो. अच्छा. बहुत बढ़िया. मैं डॉक्टर साहब से पूछा कि आप इंजेक्शन दिए क्या तो वो इंजेक्शन देना होगा. हाँ हाँ.
So it's a feedback from the patient.
ठीक लग रहा है, कोई तकलीफ नहीं है.
So patient didn't get any pain at all. So this is very rewarding technique, very simple technique. I have done some studies, and I will go to directly to the discussion part. Sorry. This is the discussion. Bleb formation, fundus, CRA pulsation, vitreous incursion, RD, pain, everything was very less as against other studies. Dramatic effect of this new technique on intraoperative and postoperative complications were observed. There is hardly any bleb formation, vitreous incarceration, rise in IOP or CRA pulsation were notified as against other studies. Less or no pain was experienced by the patient. To conclude, this is a simple, inexpensive AC paracentesis device which is found very safe for all types of intravitreal injection. I have got 5 years experience for this technique and it's very rewarding. I will appeal all the vitreoretinal surgeons to go for this technique. Thank you very much.
Thank you very much.
Most of us end up most of our injections with a single prick. It's only in selected cases where you really need to go in for a second injection or anterior chamber tab. So definitely what the technique you have shown does work in those select cases where you would expect a IOP spike.
Yeah.
Because your second needle, which is in the anterior chamber, is little uncontrolled. Because it's, so in a patient who is apprehensive with eye movement when you're concentrating on the injection, there is a potential risk, but definitely it's well thought of.
Yeah, many people are afraid of that. But what I did the modification, just the tip of the needle is inside the anterior chamber. Even if you move the needle, there is no harm.
Okay. Thank you.
Thank you so much.
Thank you. So next we call upon Dr. Shalin Sunil Shah. Are you here? And after Shalin is Dr. Shishir. Dr. Shishir, you are ready. Okay.
So, good evening, everyone. I'll be talking about obstructed meibomian gland disease, make in India against the Maskin's probes. So we have all seen meibomitis patients, chronic meibomitis patients coming to us, following with us for months together without any resolution, where warm compresses, lid massage, oral doxycycline, azithromycin, topical antibiotics, nothing seems to work. These are usually patients from the lower socioeconomic group who come to the charitable OPDs and they are not compliant with medications, they have poor ocular surface hygiene. So for these patients, for obstructive meibomian gland disease, in 2010, Dr. Maskin gave a remarkable treatment option that was meibomian gland probing. And he suggested that in 25 patients, he noticed results which lasted up to 12 months. But the Maskin's probe, it is 76 micron in diameter and its price currently for 10 probes is $285, which is very expensive, frankly, for our setups. So, and this study was followed by another study from the Chinese population who came with the conclusion that 0.16 millimeter probe has similar results as compared to the 76 micron Maskin's probe. So we thought, what cheaper alternative we have with the same diameter, and that was a 34 gauge cannula, which has a 0.159 millimeter outer diameter, a 4 mm length, similar to Maskin's probe, and we can mark 1 mm and 2 mm on it if needed. and this costs 10 rupees per needle. So we followed this protocol. We had these chronic myomitis and obstructed meibomian gland disease patients. We anesthetized them, gave them warm compresses for 15 minutes before the procedure. Then the 34-gauge cannula was used to dilate each meibomian gland orifice, and it was dilated till an audible pop was heard. This is heard by the surgeon and the patient, and we need to dilate each of the meibomian glands, like 40 in each upper and lower lid, followed by warm compresses for another 15 minutes. And these are the pictures of one of our patients, where in the upper image you can see the dilated obstructed meibomian glands, and the other image shows at 3 months where the meibomitis has resolved in this patient. So this was a pilot study. We enrolled 10 patients and treated their upper and lower eyelids, so 20 eyelids, and follow-up of 3 months after a single episode of meibomian gland probing. We excluded all patients where tarsal plate was operated for entropion surgeries and patients of chronic dacryocystitis who had an active disease or were treated in past because they have concurrent meibomian gland dysfunction. Our results, the patients were all in the older age group, mean age of 55, and mean duration of disease was 2 years, that is 24 months. We observed that the meibomitis decreased from a mean of 3.7, the grade of 3.7, to around 1.7 at 1 month, and this remained sustained for up to 3 months. That was the end of our follow-up. And the pain score was also decreased, which was documented using Likert scale. And the Monk score for epiphora, we noticed a persistent decrease in epiphora in these patients after treatment. So why this technique is important? The cost. Currently, the Maskin's probe comes at $25.5 per case, and our technique, it is only 10 rupees per case. Second, we have an option of LipiFlow, but it's again an expensive investment. So this is a simple alternative procedure. There's no learning curve. There is minimal pain to the patient, and the patient hears that pop for each meibomian gland you dilate. So he hears 80 pops, and it's like an additional placebo to your therapy. And thank you.
Did you look at the myography for all these patients and then decide which one do you need to probe? Because each meibomian glands have different orientation of shape.
Yes, sir. Sir, so in this study, this was a pilot study where we did not use meibomian gland or tear film analysis, meibography or tear film analysis, but we have an ongoing study where we are mapping and to determine which of the 40 glands we actually need to probe. This was a pilot study where we probed each of the glands irrespective of their status. But yes, it's a step forward where we could probe only the 15 or 20 affected glands and we could have similar results without damaging the unaffected glands. Thank you, sir.
Thank you, Dr. Shalin. The next speaker will be Dr. Shishir Varghese, and he'll be speaking on Glow Port.
Good afternoon, everybody. I'll be talking about GlowPort, a frugal, innovative device used for vitreoretinal surgeries. So the problem statement what we had was, we are surgeons, they operate in the dark, so they only use a microscope light for a brief amount of time for putting in your cannula. So first we place the infusion cannula connected to the machine, then we place in the right and left trocar cannulas. For that we require the microscope light to be switched on or the room lights to be on. But once we go inside, we switch off the microscope light, we put in our biome, and then we do our vitreoretinal surgeries. Now, if you want to exchange your instruments, you again require the light to be switched on, the microscope light or either the room light, so that you can see where your port is. And then again, you keep going in, coming out while switching on and off your microscope light. So this was the problem statement what we had. And so constant illumination was not possible, and microscope light needs to be repeatedly switched on and off. So this was our problem. So the aim was to have a frugal tool providing illumination for instrument exchange in vitreoretinal surgery without constantly switching on and off the lights, either the microscope or the room light. So hence we came forward with a GlowPort, which is a 3D printed device. Volume, please.
This is the GlowPort, a 3D printed phosphorescent glow device. This is compactly fitted over a 25-gauge trocar cannula as shown. The glow device can be pre-fitted and placed over the trocar. After placing the infusion cannula, both the superior cannulas are placed with the glow device on it. The glow port is then exposed to light from the microscope as well as from the endo illuminator. If you have a green laser filter, you won't be able to capture the phosphorescence in your microscope camera. Under mesopic or dim room light conditions, we visualize the glow port glowing in the dark. The glow port, with its property of phosphorescence or glow in the dark, helps us in smooth and efficient instrument exchanges during surgery without having to repeatedly switching on and off the microscope light. The photoluminescence or glow stays for 10 to 15 minutes and it regains its glow after a very brief exposure to the endo illuminator light, as is seen here. Ocular touch errors and effective surgical time is reduced for experienced as well as novice VR surgeons.
Yeah, so we designed a phosphorescent glow-in-the-dark trocar cannula for smoother instrument exchange, which was 3D printed and was utilized in real VR surgical mesopic or very dim light conditions. So to conclude, ours was a frugal, inexpensive, 3D printed novel tool with a good source of illumination. Smooth instrument exchanges were performed, and there was a reduction in ocular touch errors and reduction in the procedure time. It's beneficial for both experienced VR surgeons as well as neophytes. So thank you.
Shishir, you still would need the room light because if the nurse is going to hand over the instruments to you,
yeah,
they still need the light, right?
Yeah, so very dim light. So, but at least you don't have to switch on the microscope light.
Yeah, I think it still makes sense because you don't need to close. When you're working closer to the eye, I think it may help.
Yes.
But how do you make this material?
So it's a 3D printed material, polylactic acid mixed with strontium aluminate. So strontium aluminate is an inert material which is also non-reactive to any body tissue and all. So that's what we use for the glow rings and all those things. So that is mixed with the polylactic acid, and that's what provides the glow. So it's a 3D printed device.
Good idea. Thanks.
Thank you. Thank you, sir.
If I see that device correctly, you are putting into your needle.
Yes, sir.
So going to take a space. Would that needle length will make a difference?
No, actually, only the diameter is slightly on the higher side. Needle length, it won't make any difference.
No, just taking
so we're planning to reduce. It's around
so
the
hollow.
Diameter.
Yes. So previously abroad they have tried making the full trocar, but that was not possible because it reacts with the inner tissues. So this is just placing outside the eye. Yes, sir. Yes, sir, they can. 20 rupees for 4 pieces.
Thanks,
Thank
Dr. Shishir. So we'll go to the next speaker, Dr. Abhishek Anand. Are you here? You Abhishek?
Santosh.
Oh, yes, Santosh. Oh, he's the first. I got it. Dr. Santosh, here. You start.
Can I start?
Oh, he has not started. Getting confused.
So good afternoon, everyone. I'm here to discuss about my innovative no-cost suprachoroidal triamcinolone acetate delivery system, which is indicated in common indications like diabetic macular edema, postoperative CME, or any macular edema secondary to RVO or uveitis. Why this suprachoroidal route of delivery thought of? Because of already known complications of intravitreal triamcinolone or posterior subtenon triamcinolone, which increases the IOP as well as increases the chance of cataract. So this is how the suprachoroidal system is. Volume, please.
at infratemporal quadrant between 900 to 1000 micron. An injection set is fashioned for delivery of suprachoroidal triamcinolone 900 micron deep. For this, we took 22 gauge needle and broken it from its hub using a needle holder without much pressure. The tip is broken as well. A Castrovillo's caliper is taken to measure the exact length of a 26 gauge needle from the needle hub till the beginning of the bevel. The same caliper is used to get the exact length from previously prepared 22 gauge needle shaft, which is put over the 26 gauge needle. Triamcinolone is drawn into the 1 cc syringe and the set of the needle thus prepared is fixed to the syringe for the injection after making it air-free and keeping exactly 0.1 ml of residual triamcinolone. After proper cleaning and wrapping, the exact measurement for intravitreal injection is taken as per the length status, and the needle set is introduced into the suprachoroidal space, keeping the bevel up. The 22 gauge shaft behaves as a guard for further penetration of the needle, delivering the drug at suprachoroidal space. Following introduction of the bevel, the triamcinolone is simply injected and the injection site is sealed with a cotton tip application.
So this can be confirmed by 3 methods. The site of delivery by indirect ophthalmoscopy during just after the injection, or direct examination under microscope with a window illuminator, or anterior segment OCT, which is done in this case. This is a representative case of DME which has decreased drastically following suprachoroidal injection. And we have done a study, which is a postgraduate thesis, taking 50 patients in each arm, comparing suprachoroidal triamcinolone and dexamethasone depot. So at only 12th week, we need to re-inject the triamcinolone, and the results are very much comparable at the end with CMT and VCVA. Most of the cases had comparable result. So this can definitely be considered as an unequivocally superior method and cheaper alternative to already available methods with less complications, and definitely can be tried in all. Thank you very much.
Thank you, Dr. Santosh. Judges, please.
I'm not sure how can you compare the longevity of an action of a triamcinolone with a single dose of intravitreal dexamethasone.
No, sir. We have to re-inject in almost 6 cases in the group of triamcinolone. You have to re-inject between 8 to 12 weeks. When it is shown in the graph, I have shown.
No, you are comparing it with intravitreal dexamethasone.
Intravitreal dexamethasone 1 dose, and as and when required, repeat injection of suprachoroidal triamcinolone.
But you would expect the triamcinolone to act longer than a dexamethasone.
No, it does not act longer. It acts lesser, so you may have to repeat sometimes as and when required.
No, I would be more concerned about the injection going on. You're saying that exactly that, because the thickness in the sclera may vary. So what about those that come out? You didn't mention anything about the complications or anything you had with those injections.
We had minimal complications like subconjunctival hemorrhage, but there was no increase in IOP following the injection or no incidence of cataract formation. That has been compared.
But no injection that came out because some part of the needle, I don't know how much it penetrated inside.
Yeah, sir, there is a guard which is not allowing the needle to further penetration, which is preventing the needle to go further into the vitreous cavity because it's a metallic one, not a malleable one. So it cannot percolate beyond 900 to 1000 micron and delivers the drug in the suprachoroidal space only. And we have taken post-operative AIOC also to confirm the delivery at the
suprachoroidal
So what
space.
sir was trying to indicate is that
Between 900 to 1000 micron, most of the time. And that's why we measure, we try to see it whether it is properly delivered in the suprachoroidal space.
Thank you, Dr. Santosh. We'll move on to the next speaker, Dr. Abhishek Anand, who will be speaking on multi-stage cutting ophthalmic device with rotor. Dr. Abhishek Anand.
Thank you for this opportunity to share my idea on bit rotor. So basically, we all, as a retina surgeon, we want higher and higher cut rates because this gives us an unparalleled safety when we are working extremely close to the retina. But our current devices are based on reciprocal pneumatic cutters, which have an upper ceiling of around 10,000 cuts per minute, and this can't be. And with the more you increase the cut rate in gluton cutters, they decrease in the defective duty cycles. So the problem was to increase the number of cutting rates. There was a lot of hype few years back when Boston Law had announced its ultrasonic vitrectomy cutters, but then it gradually fizzled away. So in order to get to break that threshold ceiling, we think that the rotating tool, instead of a reciprocating tool, will have a possibility to break that barrier, and you achieve a more safer and faster removal by, if you have a rotating type of cutters, then you can do multiple type cuttings because of this rotatory action rather than a reciprocating cutter. So the innovation is that it will have a casing which will have electric. The casing will have a housing for an electric rotating actuator which will be connected to the cutter through a coupler. The operator will switch on the handpiece, which will start the disposable motor, so which speed may reach up to 30,000 cuts per minute. There will be multi-point refers to the cutting action which will take place at more than one stage, and the assembly design of the handpiece is modular. So basically, the modular says that the outer casing as well as the inner solid cylinder can be exchanged, and not the whole of the cutter needs to be changed. So these are the parts of the cutter which we have proposed. There is an hollow shaft and there is an inner solid, unlike the current cutters which have both the hollow shafts, and you have cutting at the stage 1 which is at the tip, and then you have a stage 2 which further emulsifies all the cut vitreous that goes into it. So to present it, the idea into a more animated design, so there is a hollow casing which encases a solid cylinder, and these two are modular in nature, and there is a DC motor which is connected to the back of it, and this DC motor, right now we have a DC motor which can achieve rotation up to 1 lakh RPMs also. So, and this solid cylinder has, these are two cutting edges. One is at the tip, which will have the out opening, and the other is inside the solid, inside the hollow cylinder. So once we are inside the eye, so it will rotate, and at the tip you can add multiple blades, and this can increase the number of cuts per minute you achieve. So this is the design. So in this design we can see that on the tip there is a 4 blades. If you effectively see, it's actually two blades cutting, and at the middle, which is the B point, which is also giving you further, once the cut pieces of vitreous gets further broken into small pieces, so that they don't clog the system per se. The benefit that we want to achieve is that ultra high cut rate. You make it more cheap, durable, and they leave a low carbon footprint. Till now, we have done the design and simulation. We have done the prototyping and the IPR. This was one of the earliest design, which was on a 23 gauge goiter cutter, which we did, in which we assembled all the parts. And this is the patent that we had applied for, but still there is a long way to go, and we are still stuck at the fabrication and substantial budgeting. And for this, we have applied in the ICMR. This is just our protocol. This is our timeline that we have submitted in the ICMR with the proposal, which gives us another 36 months window for the fabrication of the project. So, and this is my working team with which I am going around. Thank you.
Any questions?
Is it a single-use disposable device or a multi-use?
Sir, the whole idea of this came when we were working in various charitable hospitals, and we saw that many hospitals didn't have access to the vitrectomy system because it's a console. The console costs, plus many times if you have a console in many phaco systems, the surgeon suddenly opens and they find that the cutter is not working because they have not been cleaned. So there is the concept originated at that point of time that we must have a disposable vitrectomy cutter which doesn't cost that much. And then we planned this idea of vit rotor because our because this rotating motors, we already have a lot of rotating motors which have around 1 lakh rotations per minute also. So we started with a very simple that even if we achieve 2,500 or 3,000 and we are able to make it for the anterior segment surgeons, then all these cutting through the seizures and all these things we can get, and there will be more post-operative benefit to the patient. So that was the idea when it started, that how we can give access to vitrectomy to all the surgeons who are even in the periphery also. That is origin of that idea.
Doctor, you mentioned about the rotatory cutter, right?
Yes, sir.
Where is the cutting part of it? I was not able to understand that.
So basically, sir, there is a hollow cylinder which encases the whole thing, and inside there is a solid shaft, and this solid shaft has 2 flanges. So just like you saw. Whatever the vitreous is aspirated, then it rotates and it keeps cutting. So there are teeth at the tip. And if we increase the number of teeth, then we can multiply the number of cutting rates. And in the middle also, for more stability, we have added mesh in which all the gel that is aspirated, it's further broken down into more pieces.
The central core has got
solid
thing.
Solid cylinder, yes.
Have you tried it on the actual vitreous?
Sir, we have tried it in a bigger model. We have tried the rotation, but then the main issue that we thought that it would be very easy to fabricate. But when we started, we started communicating with the different industry persons. So it required laser cutting, laser lathe. That is what they call laser lathe, and it is very expensive. So now we have to formalize it, and then we are talking with the excellent team in America, and they have said that they have access to this technology.
Because you're talking about 23, 25 gauge, and that you are going to create that.
So 20 gauge we are initially planning to start with. So that is
20 gauge.
Yeah, we're starting with 20 with at least let's say.
Yeah, I think unless you try it on the actual vitreous, we wouldn't know how effective it is. But it's a good idea. Thank you.
Thank you, sir.
Thank you, Dr. Abhishek. That was excellent. Now I call upon Dr. Narendra Singh Verma. He'll be showing his innovation of mobile-based SI calculator.
Good afternoon, everyone. It's my pleasure to speak in such an eminent faculty to give my presentation. It is a SI calculator which will be available free to all. And it is having which can be accessed on mobile also. The limitations of present SI calculators are they require laptop or desktop, can be accessed by the members, some are paid, the registration process is very tedious, they calculate SIA by vector method only, data entry and evaluation of results is not user friendly, comparative analysis of different type of incisions is not possible. You have to fill different data sheets if you want to compare different type of incisions. SIA calculators are used to measure mean SIA and centroid SIA. For astigmatism correction during cataract surgery, mean SIA value will decide the size of steep axis incision, and centroid SIA value is used in the toric calculators. Incision on the cornea causes change in cylindrical power. There may be steepening or flattening. At the same time, rotation of the steep axis, which may be clockwise or anti-clockwise. So an ideal SIA calculator is one which can predict how much cylindrical power will change, as well as how much rotation of the steep axis will occur and in which direction. But the present SIA calculator, which are based on vector method, can measure only the magnitude, mean SIA and centroid SIA. They are not designed to measure the rotation of steep axis. The polar method can measure both magnitude and axis rotation. In vector method, we measure SIA by this simple formula. In polar method, SIA is measured in two parts, which are called polar vectors. One measure the change in the cylindrical power and another measure the rotation of the steep axis. Root square sum of the two parts of polar SIA is equal to the vector SIA. So polar SIA tell us how much SIA part is changing the cylindrical power and how much SIA part is rotating the steep axis. This SIA calculator provides SIA by both polar and vector method. Access is very easy. Scan the QR code, log in with your ID and password. There is single input data sheet for all type of incisions, phaco, SICS, LRI, etc. All the results are provided on single screen. The results include vector SIA, 2 parts of polar SIA, axis of rotation of steep axis, coupling ratio, and change in spherical equivalent. In the lower table, you will get mean, median, quantile, and standard deviation of all the results. This is centroid SIA by vector method double angle plot. It is similar to Dr. Warren Hill SIA calculator. This is centroid SIA measured by bivariate analysis of 2 parts of the polar SIA. For validation, we have compared our 10 results with Dr. Warren Hill SIA calculator, which is based on vector method, and Dr. Neil Alpine AIOC SIA calculator, which is based on polar method. The results are same. Comparative analysis of different type of incisions and other parameters is very easy. This is an example in which male more than 60 years, when incision is 1 millimeter away from the limbus, 2 to 3 millimeter in the size, and having with the rule astigmatism is compared. The system will automatically select the data and provide results automatically. So this SIA calculator is free to use, easy to access by QR code, and can be accessed on mobile also. Calculate SIA by both polar and vector method. Data entry is easy in a single Excel sheet format. Results and graph are displayed on single screen for easy evaluation. Comparative analysis of different type of incision is possible. Thank you.
Thank you, Dr. Narendra. Judges, please.
Sir, based on the other SIA, I was judged last year also. How would you differentiate yourself from the many SIA calculators which has been available? I mean, it's a very nice, innovative way of demonstrating polar and vector, and because that's what people get confused.
So Saurabh Savane SIA calculator is there, but it is not giving the plot. This plot is not there. And Dr. Warren Hill SIA calculator is there, but for every incision you have to, one ID, you can measure only one incision. So multiple data sheet you have to fill, and access is not easy. And in our method, we are measuring by polar method also, 2 components. So
that's be understood. So the second thing is it's more of a
mobile based also, sir.
More of a suggestion than the question. With the country with so much of cataract and such the best surgeons in the world, we don't have a good formulas, and these are the ones which will take us there. But what really differentiates us from reaching our full potential is we have not incorporating aggressively the AI-based systems. This machine learning, not the simple AI. So what I would suggest, sir, is if you build a platform on the same thing where people add, and that's what Warren Hill did, and it just started becoming smarter. And more smarter it becomes, it develops into a platform. So then it will go to a different levels.
Yeah, you are right, sir.
Definitely. I think looking into all IOR calculations, especially toric, whatever we do it, it's not enough. We are looking for absolute perfect results. So what Rohit says, like maybe we can all incorporate our data into that, then make something which is actually people follow ours. Good idea.
Thank you, Dr. Narendra. We'll move on to the next speaker, Dr. John Davis Akra, who will be speaking on Fundamed eye drops. Did I pronounce it properly?
Yes, sir. Thank you, sir.
Eye drops, prescriber, reminder,
my nickname is
tracker,
Funda, so Fundamed. So Fundamed eye drops. So this is an app which I am making. So the app is because we ignore one major thing that we need not only prescribe medication, we have to make sure that the patient use it properly. Ophthalmologists, we as doctors, we diagnose many diseases with a lot of thinking and diagnosing, and then prescribe the eye drop, but forget that patients have to take these eye drops correctly. And many patients use the eye drops incorrectly or misusing them just because they forgot what the doctor told them to, or did not understand exactly what they were told. And especially tapering schedules of eye drops, such as post-op medications, uveitis treatments, are very confusing. Even glaucoma medications, we keep changing them sometimes, and that changed medication may not be properly understood by the patient. And in such treatments such as glaucoma, it is very crucial. Every missed drop will lead to loss of nerve fibers. us. So even if patients find a medication app, which is, by itself is difficult, and they install it, it is very cumbersome to enter the data into the app. It is ideally done by medical personnel. There should be some accuracy in the entering of the data into the app. And our approach is to solve all these problems in one shot. So what we have done is to create an easy-to-use app for doctors to prescribe medications firstly, with error prevention, and also to transmit this prescription to the patients easily via QR code. So I call it QRX. So QR and RX. So when the patient scans this QR code, it opens this data into their app so that there is no error in the transmission. And this app also would provide reminders of the medication, and it will also track whether the medication is put on a daily basis based on patient feedback, of course. And this can be shared with the doctor later. In addition, patient can also update on their symptoms or any adverse effects that they have from the medication at the correct timeline, so that the doctor can figure out what exactly must have caused this side effect or any other change. And the app was designed with UI for both the doctor and patient. And the functions are prescribing medication for the doctor, receiving prescription for the patient, and of course on the patient side, reminding, tracking and monitoring the medication reminders. And the future things are to have drug interactions and contraindications with systemic illnesses also built in, so that when the doctor prescribes itself, it gives a warning that this medication may not be suitable for this patient. Library with existing medications has been entered, and other custom medications can also be entered separately. And we plan to have the medication reminder to have the picture of the bottle also shown, so that they know exactly, okay, this is the correct bottle which has to be used. That also has to be customized, entered by the patient later. So this is what the app would be looking like. And doctor-patient two interfaces. If you go to the doctor interface, we will have the prescription where you enter the patient data either directly or maybe in future link it with EMR. That will need some more tech support. And the medications can be entered in the tabular format. Multiple pages can be added because there is a limitation of space. I don't want scrolling. And once that is done, you can generate QR. So it generates the QRX, which can be scanned by the patient and can be used. So in the future, this should be there in the EMR itself, and the patient can just scan this QR code from the EMR. And this is how they would be scanning. They would click to open scanner and just scan the QR, and once they scan that, the prescription will enter into their phone, and that will be set up as alarms. And this will be showing up as alarms to the patient. And so that is what we want to use, an app for medication prescription, reminder, and so on. Thank you.
Thank you, Dr. John. Judges, please.
This question I wanted to ask is, in the future or whenever you want to, can we also, like this is a glaucoma week, can you add in the fields and all the OCT and other things into this so that you can correlate the how well you're using the drops to
that would be a completely that would be a much bigger addition to this app. My plan to scale this app was as a medication prescriber and reminder, not just restricted to glaucoma, but sir, that is definitely something which is feasible. So if we are having one app dedicated to glaucoma, a timeline of IOP measurements, timeline of fields, timeline of OCTs, but this one is mainly targeted as a medication reminder.
What I was trying to ask is not just the timeline, it's about correlating somebody who is very
cause and effect,
who is very religiously using his drops versus somebody, so you can predict that he was not using the drop, that's why he was showing a change.
Yes sir, that is something which can be definitely added in a glaucoma specific version of this app. We'll do that.
I think that has to get added in the EMR, the reflection should get integrated into the EMR to show that. Yeah.
Because it's very easy to generate this QR code. It's just a simple JavaScript itself can be used to generate this QR code. It can be very easily added to the data on an EMR if they just have to give us permission to do it.
But John, the major problem is in compliance. Whatever app, whatever we do, the patients still tend to...
A lack of understanding, forgetfulness, that is some major part of this. So once that is taken care of, we would take care of a majority of the patients. This is just an alarm. So when they hear an alarm, they look at the phone, they see the picture of these eye drops. They should be able, and if you want, we can have an audio telling the name of the medicine, or so low vision patients will have difficulty, of course, but we can have something which they can easily see by color or something. Can be done.
Thank you. Thank you very much. That brings us to the end of the session. I would like to thank all the finalists who were here. They all had wonderful presentations. I would like to thank the judges and the panelists. Special congratulations to Dr. Kasturi for organizing this wonderful event today. I would like to request Kim sir to please give a certificate of appreciation to Dr. Chitra Ramamurthy ma'am. Kasturi, you can assist. Ma'am, you'll have to come this way. Dr. Asim Sil sir. Dr. Kim sir, you'll have to stay here. Who next time? Next time. Thank you. Yeah. Dr. Girish Rao. Kim sir किधर चले गए? Dr. Kim. Professor Jeevan Titial sir. Dr. Rohit Shetty. वो कहाँ गया? मैम बोला? नहीं, आपका कहाँ गया? शुरू में ही हो गया. हाँ. Okay, one to me. And I'd like to request. किसको बोल रहे हैं? आपका कहाँ है सर? असीम सिल, आपका मॉर्निंग में हो गया क्या? एवरीबडी. हाँ दे दो. अच्छा हाँ. Can I request all the speakers to please come up for a group photograph?
So you have not given me my certificate.
Three. Dr. Asim Sil को देना है वे certificate. Here. All marks are here. I'm giving you 3 sheets. है ही नहीं, इस हॉल में है ही नहीं. Thank you. I'd like to request TTL sir to please give a certificate to Dr. Asim Sil.